Sir, you can start the session.
Okay, thank you. So good evening to all of you. As usual, I will start with two short cases first. Sorry. Can you see my slide?
Yes, sir.
Okay, right. This is a story of a 70-year-old man. He noticed weakness of right hand on getting up in the morning 1 week back. No other complaint. He said the only difficulty he found that he could not tie his dhoti. Dhoti means what you call in Malayalam we call munda, dhoti with the right hand. This is the only complaint, and let's say his story is that he could not tie his, that is the only complaint. He said no other complaint. Examination, L3 was normal. Biceps appeared normal. Biceps normal. Wrist extension normal. Finger extensions were normal.
Maximum picture. That's also good power.
Kept also normal.
Or
finger extensions were normal. Normal power.
Maximum okay.
The reflexes appeared normal. No difference between the right and left side. Anterior was downgoing. Lowerly muscle power all normal. Started examining the sensory system. Is it same? No difference. Again normal. So what is the diagnosis in this patient? What will you like to do? What any of the investigation like to do? For examination, you like to, pardon?
MRI brain.
MRI brain. MRI brain. Okay. Anything else you would like to do?
So how the small muscles are found?
Other muscles were, which small muscles were normal.
MRI brain stroke protocol.
MRI brain normal. Stroke protocol.
High cortical cuts.
Pardon?
High cortical cut is also taken, sir. MRI.
Yeah. Every cut was taken.
Flexor pollicis longus powers.
Very good. So neck contestant was done. The sensory potentials are absent bilaterally. Not very important. Because and the motor contraction was normal. Median, left median normal, right median normal. Right ulnar sensory normal. Now let us see what I have done. This is the pointing index sign. When he has to clench his hands together, you can make out the thumb and the index finger. Index finger weakness. That's on the left side. Flexor pollicis brevis is normal, but longus is weak. That is longus. That is weak. Okay, so what he has is anti-interosseous palsy. The point, this case, in fact, last class I told you I'll be showing one neurologic hematrophy can present with only one nerve involvement. So he has only selective involvement of the flexor pollicis longus. That is, that may be the only muscle affected in intractable neuritis sometimes. Improved after some time with steroid. It can rarely occur as intraocular neuropathy, but more often it is a variant presentation of brachial neuritis. It has been reported to occur following fractures and crush injuries. And this is the, I think I'll skip all these things in the interest of time. This anti-interosseous nerve. Now, this is a presumed site of lesion is here because, why? Because he has got the flexor digitorum profundus is spared, but the pollicis longus is affected. That is a probable site of why the long finger flexors are all spared. Okay, sometimes this can occur. In fact, some time back I had shown a patient with a girl with radial nerve palsy. The only problem was here extension of the extension of the thumb. Thumb will not flex. When she was a dancer, I don't know whether you remember that lady. She's a dancer. She said you could not make mudra with the thumb. That's the only complaint. Examination showed extensor pollicis longus was weak. No other muscle weakness. She had a conduction block in the radial nerve and she improved after short course of steroid. Someday this kind of varied presentations can occur in neurologic metro. Okay, any questions? Very often this kind of testing will help you. Do like this, check for the long finger flexors and the foramen signs and the nail sign and the O sign. Those things will can make and it give an immediate diagnosis to, immediate help to arrive at the which muscle is affected.
Can it be entrapment, sir?
Pardon?
Entrapment, can it be pressure palsy?
Very unlikely, because the thing is he got up in the morning. The only problem was that he could not press his thumb into to tuck his dhoti. And entrapment means it should affect the other muscles also separate the anti-interosseous nerve. It is not affected. Other flexor digitorum, longus, sublimis are all normal. Initially, when I checked all these are all good power. Only thumb was affected. Okay. Shall we go to the next case? Okay. So the 50-year-old lady, she noticed deformity of both the thumb for the last 4 years, which according to is persistent all the time. That was not bothering her much. She noticed abnormal posturing of the right middle finger, ring finger, which is episodic and occurs mainly on taking food. She says whenever she takes the food, the fourth finger will go, flexes into the thumb or approximates into the palm of the, not thumb, palm of the hand. I'll show the video of that thing. She also gave history of tremulous movement of both fingers for the last 2 years. So short history. Notice deformity of the thumb for the last 4 years. Then notice abnormal posturing of her right ring finger whenever she takes food with the right hand. History of tremulous movement of both hands. Look at the deformity of the thumb. It's hyperextended at the metacarpal, the first metacarpopharyngeal joint. The other fingers are not. That is the position of the thumb. We can see that. It's hyperextended at the metacarpopharyngeal. That means the tone was normal, shoulder power normal, biceps power normal, biceps normal, normal. The finger extents are also normal. Finger flexors are all normal. Then you start examining internal muscles. The abductor pollicis was combined in the base of the metacarpopharyngeal joint, but there was power was normal. This also left side also normal. The flexor pollicis brevis was also normal power. Longus was flexor pollicis longus normal. Extensor pollicis longus is slightly weak. So you can see you can overcome easily. That is weak bilaterally. The interosseous were normal. The finger abductors were normal. There's no pointing index hand or anything in this patient.
പിടിച്ചോ 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 പിടിച്ചു
The
നിർത്തണേ
extensor pollicis longus is normal.
പിടിച്ചു നിർത്ത്
Sorry, in a brevis was normal.
ഇത് പൊക്കിക്കാം
But only extensor pollicis longus was weak.
അകത്തോട്ട് പിടിച്ചോ
Flexor pollicis brevis.
ഇതെടുത്ത് പിടി
These are also interosseous or palmar interosseous also normal.
അതിനെ പിടിക്കുന്നു
On doing the foramen test, this appeared positive. There is flexion of the distal interphalangeal joint. Lowerly muscles are all-
മുള്ളോട്ട് പിടി മുള്ളോട്ട് പിടി
The reflexes normally elicited. Plantar ongoing. And sense system examination also normal.
ഇതും ഇതുവരെ അറിയാം അറിയാം അല്ലോ തുടർന്നൊക്കെ അറിയുന്നുണ്ടല്ലോ ഇതറിയാവോ ചിരിക്കലാന്ന് ഇതറിയാവോ ഇതോ ഇതോ
Postural tremor of both hands. And it was normal. Just with the knee joint problem, that's why she's walking like that. She could stand on heel and stand on foot. Sensations were also normal as told before. The second part of the video, she's complaining of involuntary flexion of the ring finger on the right side. So made her right. Writing was okay. She did writing was not changing the handwriting per se. Except for the abnormal positioning of the thumb, you can make out the thumb abnormal position. Then asked to imitate how you should take food with right. Tisha's little finger will jut out like this sometimes. Then ask you to imitate how you take the food. She's taking the food. See, the fourth finger goes inside. The fourth finger gets flexed. See the fourth finger. The ring finger goes back. On the left side, it is not there. She's taking the food with the left hand. I'll show that video once again because writing is normal, I think. And see the little finger on the left side also is jetting out. On the left side. And see the right little finger is coming out like that when she holds the pen. And see the right finger, little ring finger goes inside. She's taking the food now. The fourth finger is going inside. Okay. So in examination, she had bilateral postural tremor. Both thumbs were hyperextended at the metacarpophalangeal joint, which can be corrected passively. Power weakness of extensor pollicis longus, I forgot to mention longus, but okay, pollicis very was normal. Foramen is positive bilaterally. Rest of the muscles normal. DTR all normal. Plantar downgoing. Sensations all normal. While miming the action of taking the food with the right hand, the ring finger goes into flexion. So this is the findings in this patient. So what do you think is likely diagnosis of this patient?
Task-specific dystonia, sir.
That's dystonia, very good. It's a focal dystonia affecting the little finger and the ring finger. Little finger goes in the abducted position and the ring finger goes in the first position. So and also the tremor also can be explained by the dystonic tremor. Most of these people have tremor also. But what is causing her? So that's okay. But thumb deformity, what is the cause of her thumb deformity?
So it's a long-standing lesion.
Yeah,
So
it has been there for long. I agree with you. It has been there for long. Look at the hand now. I'll show the hand. See the thumb once again. See, this is the position of the thumb. Distal part is flexed. The metacarpophalangeal joint is extended. The carpal metacarpal joint is flexed.
Might be a congenital malformation or a tendon transposition or something like that, sir.
Okay, very good. Maybe local pathology, correct?
Yes, sir. Local pathology, sir.
Now, she had an apparent weakness of the extensor pollicis longus, as well as some foramen sign was also possible. You saw that, the foramen sign. How to explain that thing?
Maybe some contracture of the tendons, which is making it difficult to do the
No,
formation.
I look for that. I told you it could be. I see passively move the thumb. There is no restriction. I told the deformity can be passively corrected by movement. That tells you it's not a contracture of any tendons.
So since there is no any sensory involvement,
Yeah.
Both motor nerves involved only for the specific muscle is very rare. So
Very,
still
very
we
good. Perfect. Yeah, what your logical thing is perfectly correct. I agree perfectly with you. So what could be the deformity? What could be the explanation for the deformity?
So I don't know, sir, but I can tell it is not. Sorry,
Okay,
sir.
what you said is correct. I also did not know. So I looked up. I thought it cannot be explained by a nerve involvement because that apparent foramen sign and the apparent weakness can be due to the abnormal posture of the joint. So when for a muscle to act, it has to be the limb, the bone or the limb has to be in appropriate position. If that posture is relaxing that particular muscle, it cannot act as a agonist. So that is probably this weakness is a spurious weakness. So I look for the literature to find out what is causing the deformity. I'll tell you what is the deformity. So I did a conduction study to find out now the conduction was normal. So this is the deformity. This is called carpometacarpal joint arthritis. So you look at the finger of the patient, exactly like our patient. Flexion of the carpometacarpal joint, extension of the metacarpophalangeal joint, and flexion of the interphalangeal joint. See, the most common cause of chronic thumb MCP means metacarpophalangeal joint hyperextension, is a basal joint arthritis, where the thumb metacarpal bone and the trapezium bone becomes inflamed and damaged, leads to ligamentous laxity. Loose or damaged ligament around the MCP joint can instability and hyperextension. Collapsed deformities thumb are common in the presence of CMG joint arthritis. This is called intrinsic minus thumb deformity. This kind of deformity is characterized by carpometacarpal joint flexion, as you can see in the diagram here, and the metacarpophalangeal joint extension, hyperextension, that is the one which we have observed in our patient also, and interphalangeal joint flexion, something like an Z like this appearance. That's intrinsic thumb deformity. Here, hand becomes highly dysfunctional posture over a time due to loss of MCP function, web space shortening, and thenar muscle atrophy, making the moving the thumb away from the palm impossible. That is why she has got a spurious foramen sign, because she cannot approximate the thumb to the rest of the palm in a forceful manner. The causes can be many: colon vascular disease, inflammatory disease, trauma, and some other things. Okay, whatever it is, you should remember this particular deformity is quite common due to an arthritis of the carpometacarpophalangeal joint. Okay, I just thought it's good as a short case because sometimes you may mistake for a nerve involvement or something. So you should be aware of this deformity. Okay, any questions before I go to that? Long case, that's just a long.
The original
Pardon?
complaint came with, sir, is dystonia only, no, sir?
Yeah, she came with only dystonia. In fact, when you observed the thumb was like this, I was curious to why the thumb is like this. That is, started examining each and every muscle in this patient. And this was, when I got the weakness of these two muscles, I got intrigued. I don't know how could I explain that thing. Then the only way is that because the abnormal position of the joint, the muscle cannot act fully in their optimum fashion.
Sir, the etiology of dystonia is just segmental dystonia.
Yeah, it's a focal adult onset focal dystonia.
Okay. Sir.
Rather task specific dystonia, because when it gets only while eating the food, the thumb goes into flexion. Okay, shall I go to the next case?
Yes, sir.
Yeah, this is a long case. This is a story of a 24-year-old male. I examined long back in 2021. Patient was apparently all right until 2015. That's when he started. It's a long history. At the age of 18, that is in the age of 2015, his initial complaint started as difficulty in speech in the form of slurring and undue separation of the syllables. Within 1 to 2 days, patients noticed her swaying while walking, and once he fell down from the bike as he was unable to maintain balance in the sitting position. His mother noticed that he had difficulty in cupping his hand to take the water from the for washing his hands after taking food. He also complained of double vision. He had no other weakness of the limbs nor any sensory complaints. So primarily ataxia and dysarthria and some difficulty with double vision and cupping of hand, whether it's ataxia weakness would not. He was admitted in a major hospital. This is a past history. He was admitted in a major hospital for 1 week and put on treatment, and his symptoms apparently improved. His diplopia totally disappeared. His speech and imbalance while walking improved to a great extent, and was doing his activities normally. So this is the first MRI which was taken in 2015. You can see some hyperintensity in the brainstem, especially in the midbrain. This is the pons, the dorsal part of the pons and the midbrain. Hemispheres were cut normal. This is hyperintensity in the coronal cut. You can find out the midbrain hyperintensity there. This is a sagittal cut showing the hyperintensity. So this is the T2 weighted sequence. Again, you can make out the hyperintensity in the midbrain there. Hemispheres normal. T1 weighted sequence normal. So what do you consider at this point of time? If we had seen the patient at this 2005 with this finding, diplopia, ataxia, and hyperintensity.
Likely
NMOSD.
Yeah, correct. Some kind of a demyelinating disease, maybe NMOSD, or this is the thing you have to keep in mind.
Maybe
Okay.
space occupying lesion also, sir.
Yeah, very unlikely acute presentation with recovery, and there is no mass effect. Only T2 hyperintensity. T1 was normal. Contrast study, I do not know whether it was done at that time. Possible.
Sir, can it be Wilson or something? They thought midbrain is on.
Yeah, we can answer it correctly. Wilson disease definitely can produce midbrain hyperintensity, but usually they also got a basal ganglia hyperintensity, but terminal hyperintensity is usually there. So it was not there in this patient.
Okay, sir.
It's a good possibility. Perfectly agree with you. So this was thought, this is their diagnosis also. You can see the research summary 2015. They thought demyelinating lesion, the lower brain, upper pons, choremus, to be kept under follow. That's a perfect way to approach. The story continued. Next year, that is 2016, following an episode of fever, he developed emotional incontinence in the form of excessive, uncontrollable laughter. This was followed by weakness of all 4 limbs, making him bedridden, and difficulty in swallowing and tremor of the head. He had difficulty on looking to the left side. He developed altered sensorium and incontinence of urine. This time also he was hospitalized and treated. His emotional incontinence and slurring speech and weakness improved and started walking except for mild impairment. So here again he had severe ataxia and along with weakness of the limbs, and was also having some problem in looking to one side. Sexual muscles are affected, and then followed by altered sensorium, and then improved. The examination at that time was reported to show failure of abduction of the left eye, restriction of failure of abduction of the left eye, and restriction of abduction of the right eye, with nystagmus of the right eye, most likely sensitive INO. Spasticity of both upper and lower limbs were grade 3 power, and all DTR were brisk, and cerebellar signs plus. This is from their discharge summary on the second admission. They just an MRI was done, second MRI was done. That is 1 year after the previous MRI, which was already shown earlier. This is second MRI. Again, it shows hyperintensity in the dorsal part of the pons, and also in the ventral part of the pons, in the region of the basis pondis, not only the tegmentum, but also the basis pondis, symmetrical hyperintensity there. And throughout the midbrain, there is a hyperintensity. Then going to the upper cut, that's enlarged view of the previous one. It is seen also in the internal capsule. That's the midbrain, internal capsule, proceeding with the internal capsule. Hyperintensity could be, but symmetrically seen. This is coronal cut again showing the hyperintensity in the internal capsule descending down to the crus cerebri. You can see the hyperintensity in the crus cerebri typically can be seen. This is a flare sequence only confirming the hyperintensity there anteriorly in the basis pondis and tegmentum, as well as in the whole of the midbrain. This is the flare sequence again showing the midbrain, post limb of internal capsule, and the corona, some cortical white matter is also hyperintense. Asymmetrically more on the right. This is that area is hypointense in T1 weighted sequence. Gradient was normal. There is no blooming seen. Diffusion was not showing any diffusion restriction. This is a T1 showing hypointensity in the corresponding area. Symmetrical hypointensity. Now, what will be a possibility now at this point of time?
Autoimmune causes to be considered, sir. And RSACs, because bilateral click hyperintensities will be seen in RSACs, sir.
The easy history process sensitive of RSAC syndrome, not at all fitness RSAC, no. RSAC is a progressive disease, and the classical thing is spasticity. Moreover, you can, as you said correctly, but the typical MRI finding is not this one. That is due to streak-like hypointensity in the pons.
Okay.
Could it be another demyelination or any leukodystrophy, sir?
Yeah, leukodystrophy is a good. The thing we have to keep in mind is that look at the pattern, it is symmetrical, right? It's almost symmetrical. So look at the brainstem also symmetrical. So when you get a symmetrical hyperintensity,
Metabolic, sir.
yeah, right. You have to think of a neurometabolic disease or something like a leukodystrophy or a neurometabolic disease has to be kept in mind. But here the problem is that unlikely for leukodystrophy, because the presentation is not like initially acute, then improved, again worsening with altered sensorium. So altered sensorium is that's very unusual for any
This repeated crisis-like presentation, some form of mitochondrial disease, can it be?
Yeah, that's a best of us. So you have to think of a neurometabolism, most likely mitochondrial disease, or some other organic aciduria, these conditions which can present like worsening with fever, you have to keep in mind. Okay, let us see, that's a possibility. So the thing we have to keep in mind is we do not know what it is, some neurometabolic problem in the form of, as you said, mitochondrial disease or something else. So that's the first step to conduct. And why? Because the symmetrical MRI findings and precipitation by fever. Multiple diseases classically precipitated fever. So also many other diseases like fatty acid oxidation disorders are all precipitated energy. Those diseases mediated by energy-dependent pathways like carnitine deficiencies. Those are all precipitated by fever things like that. Glutaric aciduria, they also can present precipitated by glutaric acid can present encephalopathy as well as with muscle weak. Different types of presentation are there. So he was admitted again 1 year later with recurrence of tremor of head as well as tremor of both hands, impairing his activities like eating food, dropping things from his hands, followed by altered sensory. These symptoms were also preceded by fever. He improved partially with treatment, sensorium improved, but walking difficulty, tremor, stuttering, which now continued. So after each episode, his residual deficit is persisting, not coming back to normal. So MRI was done 2 years later, the third MRI. This is the third MRI. Showing that, see, the midbrain has gone on to atrophy now. That size has come down, something like our morning glory sign is you see in the PSP. See the classic atrophy of the midbrain. The appendage has come down. And look at the sagittal diameter of the midbrain also. I'll show the three things later on. Appendicity is there in the crus cerebri. See the atrophy of the midbrain. Now see the evolution of MRI findings over years, 2015, 16, and 18. Look at the anteroposterior diameter of the midbrain. It is progressively coming down from here to here and last one, this one. So the atrophy of the brainstem is midbrain is progressing. The story continues. Then 2021, that is 2018 was the last MRI taken. That is after 3 years after the last MRI. That is 6 years after the onset of illness. First start 2015. Presently, he is admitted in the state of altered sensorium following a respiratory infection. Sensorium improved after control of sepsis. He was examined 1 week later when he improved from the sensorium. That is why when I saw the patient for the first time. Rest of the things were in the past history. So I took the video of the patient now. That is 2021. You can see it's got a titubation. Speech is staccato and Paravur is telling. Yes, look at he's got adduction failure on both sides.
Okay, I'm talking that there's no okay.
See the adduction failure on the right side. Left adduction is low. See the right eye is not adducting. Look at the right side. Left eye is adducting, but so the muscles were normal. Examination of the limbs. The right side, right upper limb hand was weak. Left side is okay, lately normal. He has got weakness on the right side. Again, left upper limb is almost normal. Right is weak. Severe incoordination in both upper limbs. And it was weak. Fingration is also weak on the right side. Normal on the left side. That is weak on the right side. This extension was more powerful than the reflection. The lower limb, there is wasting of the legs below the knee. And there is bilateral weakness of both lower limbs. Not zero, but 2 to 3 power. You cannot keep it flexed. More weakness in the right compared to the left side. Bilaterally, those plexes are weak, more on the right side. Plantar pressure is also weak bilaterally. Giorgio is slightly brisk. Right biceps supinator well elicited, but triceps left upper limb more reflexes were absent. Finger pressure is also absent. Both knee and ankle checks were absent. Plantar flexor. Sensation grossly normal. His weakness of both lower limb. So these are the findings in this patient. So he has got titubation, cranial nerves bilateral, INO, left more than the right more than the left. Left side there is only adduction tag which could not be seen very clearly in this video, but you can make the right INO. Rest of the cranial nerves are normal. At wasting of both the legs. Power on the upper limb, weakness of wrist flexors, finger flexors, the right hand. Other muscles were normal. Power on the lower limb. Actually, the other muscle also weak to an extent because you cannot, the finger is weak to some extent. Weakness lower limb, weakness of both hip flexors, extensors, subductors, hamstring dorsiflexors. Knee extens plantar flexors are also weak but relatively good power. Cannot sit without support. DTR all absent except for the right biceps and supinator check. Plantar flexor, sensations all normal. Cerebellar signs, scanning, staccato speech, incoordinate upper limb, lower limb difficult question with significant weakness. So, now where is the site of lesion in this patient? Which are the systems affected? But that only you can plan further investigation to localize.
So his vision, sir.
Vision is normal, visual acuity is normal.
CPK, sir.
Pardon?
CPK, sir.
No, I am talking the investigation will come later on.
Midbrain and brainstem, sir.
Yeah, one classical thing is yes, what all things we found, yes, got INO1, indicating definitely the pathway, the internuclear, the MLF pathway is affected. Bilaterally, so that may be in the midbrain, that may be in the pons, one. Second has got a bilateral cerebellar signs with titubation, indicate either bilateral semi-hemispheric lesion or is peduncular lesion. So the midbrain, as you said correctly, can explain all. You can, any NO can be explained because the superior cerebellar peduncle is affected. You can all these cross cerebellar signs can occur in superior cerebellar lesions. So that is one site of lesion. Okay. Then the next question is what is causing his weakness? You got element weakness, no? Probably upper limb you can say maybe UMN, but definitely it's got an element weakness in the lower. But a wasting weakness with the reflexia.
Peripheral nerve.
Yeah, maybe multiple peripheral nerves. So it's got a multi-system involvement, brain plus
Sir, since
CNS.
involved pure motor syndrome, sir. So muscle NMJ is possible, sir.
The muscle is very unlikely. We know why. Reason is, see, the involvement is not a selective involvement like a proximal or a distal. All muscles are affected in the lower limb. And the upper limb also is closely asymmetrical. Right upper limb affected, left is not affected. So that pattern is very odd for a muscle, and the reflexes are also down. Sensory, as you said, is a point favoring, but the overall picture is not like a muscle disease.
So then multiple radicals possible, sir?
It's also possible. Multiple, it's clearly element, whether it's a motor radical or a motor peripheral nerve, it will be difficult to differentiate. Okay, that's a possibility. Definitely, you have to keep in mind. Something involving the radicals in the subarachnoid spine, like a pachymeningitis, involving all throughout. Very good. That's also a possibility you have to keep in mind. The only way to differentiate that thing is by nerve conduction study. If in a diffuse involvement of the element weakness, whether it's extensive radiculopathy or extensive multineuropathy. Yeah, please. So that's the way to differentiate will be our nerve conduction study can help.
So when we consider mitochondrial, sir, Karen sir, where there will be one of the criteria will be increased CSF protein, sir. So when CSF protein is elevated, the motor radicals can be compressed, and the patient might have a element-like picture, sir.
So theoretically, that's possibility is that protein elevation in kern size is not that high. That is usually described in very high protein elevation that causing like in the CADP and all.
Okay,
so that's little odd for a protein causing radiculopathy is very rare.
Okay, sir.
Okay. So one is site of lesions midbrain, MLA bilateral CP. There is the same thing as multiple parallels with anterior considered because of the pure motor involvement. So MRI was taken now, that is on 2021, that is 6 years after the first MRI. This is MRI. Here the brain, the cerebellar atrophy is set in now, and there is hyperintensity still persisting in the dorsal aspect. Same hyperintensity is exactly symmetrical, bilaterally dorsal aspect, anterior symmetrical, like a dot-like thing. Again, some tegmentum and crus cerebri is hyperintense. Hyperintensity is see the degree of symmetrical involvement bilaterally. The external capsule also become hyperintense. Internal capsule and thalamus, posterior limbopental capsule. And the same, not much of a difference in the previous one. Again, the hyperintensity can be seen bilateral. So it will cut in atrophy of the midbrain. Contrast was not helpful, did not show any contrast enhancement. So also diffusion or SW did not help in this patient. And look at the evolution of the cortical atrophy apart from the midbrain. Look at the Sylvian fissure on the right side and the left side. In 2015, there is a Sylvian fissure. 2016, little more atrophy, and little more atrophy on 2018. There is also progressive cortical atrophy is also occurring in this patient. Now what else you need now?
Lactic acid, is it mitochondrial?
Right. So MRI cervical spine was also done. That is normal. And the whole spine screening was also done normal. The next question is, what is causing cell element weakness? Okay. So unfortunately, the problem is there is an incomplete study because this was done before I went and examined the patient. So they did only partial testing, only 2-3 of this. I don't know why they did like that. The median amplitude was low, left was okay, ulnar was normal, and the FA, they did the FA, that is okay. And not okay, down the peroneal, the FA was absent. So the sensory potential are all not done. So it's an incomplete study. Anyway, the element clinically it is element weakness. Now, anyway, that only shows the localization. We are interested in the etiology. So what other tests you like to do?
Could it be leaks, sir? Adult onset leaks, sir? Lactic acid can.
Right, perfect. Okay, that's a very, very good diagnosis. So mitochondrial cytopathy is the one, whether it's leaks or something, let's see that. Or a neurobasic disease. But only thing, what is again neurobasic disease, this is not the classical MRI, what is called cascade sign and all. There is clinical picture also, it has no other features of basis like orofacial ulcers or scrotal ulcers is not there. So again, that this one condition which can have a remittent relapse, that also you have to keep in mind. So spectroscopy, these are two things we want, CSF and spectroscopy. Now this is a CSF protein, 30.6 milligram per deciliter. CSF lactate 14.6, normal value 10 to 22. Serum lactate 6.7 milligram, normal 4.5 to 19.8. Patient cannot afford any genetic study, and this was done in 2015. Means the genetics was not very common, and in this part of the country at this time, at that time. So this is lactate, CSF protein and lactate 14.6. Serum lactate. Is the value significant? Yes, it is significant. I'll tell you the reason. See, the CSF lactate level more than 19.9 milligram deciliter is the most reliable variable for identifying patients with mitochondrial disease affecting the CNS. But when the blood lactate concentration is marginally elevated, the lactate, CSF, and blood ratio more than 1 or 0.91 may also provide diagnostic information. Our patient CSF serum ratio is 2.17 because CSF is much higher than that of the serum lactate. That is the point by which you say it's likely to be a mitochondrial or the disease causing an anaerobic metabolism. That's mitochondrial disease. You got the point. See, the absolute value is within normal limits. It is within the range is normal. Range is normal. But if you take the ratio of the CSF and the serum one, the CSF value is much higher than that of the serum. So let's say they take the ratio is taken as concern. That's such type of mitochondrial disease. There's a Maris also showing an elevated lactate. So most likely it's, as you said correctly, it's an adult-onset Leigh disease. Now this is an article, so it can also occur in adult. Classically, Leigh disease is a disease for the children, but can occur in adult also. Now this is from the literature. This is a 37-year-old female, present with protracted pain, abdomen, vomiting since 3 months, followed by giddiness, headache, and diplopia since 15 days. Neural examination revealed bilateral horizontal pulse and gait ataxia. Fasting serum lactate was elevated. CSF lactate is also elevated. And see the MRI picture, just like our patient. See the hyperintensity in the dorsal aspect of the midbrain. Like this aspect. I also showed a lactate peak, just like our patient. Was considered as a patient. They started on coenzyme, riboflavin, etc. And they according to the literature, that particular patient, he improved dramatically. Notice him. That's what they have written. This is after treatment. They have also shown the MRI after treatment that hyperintensity has improved or cleared. This adult-onset Leigh disease tends to have less incidence of development delay. In contrast, they have cranial disturbances, pyramidal and cerebellar signs. Okay, these are some of the MRI pictures of Leigh disease, not necessarily being adult. See this, look at the picture, all hyperdensities are symmetrical. This is from the crus cerebri, just like our patient. And the basal ganglia, the foramen. They can even say subcortical white matter can be affected, but again, look at the symmetry, almost symmetrical involvement. They can show diffuse restriction as well. And say again, just like our patient showing the hyperdensity. Okay, that's the story of the patient. This patient, in fact, we had given the cocktail, whatever is available with us, but did not show much improvement. Probably he must have received those things initially, but as the disease advanced, he may not have taken the medication for long. because I am seeing for the after 9 years of on the onset of illness. So any questions?
So will they improve with the cocktail, sir?
And that is this particular case history. They say this improved from the treatment. My patient did not improve, but according to this one, they said, see, this is what they said. And they showed improvement in the MRI also. This is after MRI. Then the MRI, previous MRI, this is the previous MRI on the patient. This is after treatment. So definitely there is improvement.
Family history, sir.
No family history of this illness. No family history. Born of non-consanguineous parent. No, just because since there is an this sort of MRI picture we find before, in addition to considering the Leigh disease, you have to keep in mind other DDs also in the back of the mind, which can mimic this kind of an MRI. As somebody pointed out, it can mimic the endoscopic spectrum disease that can produce the hypertension in the endoscopic spectrum disease. In the dorsal aspect of the midbrain, you can point out here, the arrow is pointing it out. So that possibility you have to keep in mind. Second, then neurobasal disease also can have dorsal brainstem hyperdensity like this. Then Wilson disease, as somebody's pointed out, hyperdensity here. But classically, they have basal alignment also. This is another story. Patient with diplopia impaired mental status after long-term parental nutrition. So what could be the diagnosis here? This title, this got a very good. This because when you get motor cortical hyperdensity, diffuse restriction here, think of Wernicke's encephalopathy. It's a typical one. That also can show dorsal hyperdensity in the brainstem. Showing hyperdensity involving putamen or necrotic damage. What condition can you suspect? With necrosis.
Carbon monoxide.
Very good. Carbon monoxide is one, the other is methanol poisoning. And when you get T1 hyperdensity, think of hepatic encephalopathy. And this is called earphone, just like an earphone, no? Headphone sign. Headphone sign, and this is the dentate nucleus hyperdensity with the headphone sign is seen in.
Cerebral xanthoma, sir.
And then, pardon?
The metronidazole.
Metronidazole toxicity, correct. Because the characteristic it affects the dentate nucleus. So this only for to completion's sake added these pictures, not related to our case.
The dentate hyperintensities are seen in cerebrotendinous xanthomas also, no, sir?
Correct. It can be seen several xanthomas, is correct.
Thank you.
Okay, shall I go to the one more case, short case?
Yes, sir.
Okay. This is a 27-year-old female. History of aching pain on the right side of the neck, spreading to the right shoulder for the last 4 months. Similar aching pain on the left side for the last 1 month. Clumsiness of both hands in the form of inability to hold a cup or write for the last 1 month. Difficulty in elevating both arms for the last 2 weeks. Difficulty in walking in the form of inability to push a right leg forward compared to the left side. Hesitancy and mixation for 2 weeks on leading question. So go back to the history. Started as aching pain in the right side of the neck and right upper limb 4 months back. Then 1 month later occurred similar aching pain on the left side. Then clumsiness of both hands. And then difficulty in elevating the both upper limbs. Difficulty in walking in the form of some heaviness of the right lower limb. And hesitancy and mixation. This is a story. Now, on examination, has got examination mild spasticity and bilaterally more on the right side. See the spasticity of the distal muscles. And hand grip was weak bilaterally. Shoulders was weak, just 3 to 3 plus power. Biceps was weak. Triceps was normal power. Finger wrist extensions was weak. Finger extensions was weak. Small muscles are also weak bilaterally. Interosseous is also weak bilaterally. So both the proximal distal muscles were weak. No incoordination of the upper limb. The lower limb, there's no definite hypertonia. It's mild suspicion of hypertonia. Hip flexor appears weak. Knee extension was normal. Hip abduction was normal. Hip adduction was normal. Hip extension is normal. Dorsiflexion was also normal. Very mild weakness right side, but otherwise normal dorsiflexion.
Very good.
DHL was also normal. Plantar flexion normal. Georgic is brisk. Brisk Georgic. See, quite brisk Georgic. Upper limb movements are also brisk. Finger flexion was elicited on the right side. Left side also there, not very prominent. Both knee jerks are markedly brisk. Ankle jerks are normally just slightly brisker side. Plantar upgoing bilaterally. Undoubted appearing plantar. Sensations, touch sensation is normal throughout.
4 5 6 7
There is no pain level anywhere. No difference between the upper and lower part of the knees. Vibration thumb is normal, but impaired in the little finger. He said no. There is able to feel. Is able to feel. But little finger, she is not able to feel. Lower limb of the toes is able to feel normally. Joint presence sense is impaired in all the fingers. Thumb also is impaired. Feet also is not able to feel. Can stand with eyes open, but the moment he closes, she falls down. Gait is normal, almost normal, mild suspicious spasticity on the right lower limb, otherwise grossly normal. Mild spasticity, right lower limb tracking is there. Tandem walking is defective. So on examination, cranial nerves all normal, no Horner syndrome, Georgic is brisk. Motor, tone, upper limbs, spasticity of both upper limbs more on the right compared to the left side. Lower limbs, normal tone, both the lower limbs, mild spasticity in the right lower limb. Power, upper limbs, shoulder abduction and biceps grade 4+4. Elbow extension normal. Wrist flexion extension normal. Weakness of finger extensions on both sides. Hand grip weak bilaterally. Weakness of all interosseous. Lower limb, mild weakness of hip flexors, whether it is cooperating or not, not sure, there is mild weakness. But all of the muscles appear normal. Hip extension was normal, knee extension, heart extension, abduction, dorsiflexion, plantar were normal. Detail both upper limb all brisk. But right finger flexion was brisk, left was just elicitable finger flexion. Both lower limb, both knee jakes were brisk, ankle jakes are also brisk. Plantar both are extensor. Sensory system, touch and pain normal in both upper and lower limb. Vibration in the upper limb impaired in the little fingers of both upper limbs, normal in other fingers. In the lower limb, vibration was normal. GPS sensation impaired in all the fingers and toes. Not only little finger, thumb also impaired bilaterally. So also all the toes are affected in the lower limb. Rhombox is positive, gait normal, maybe mild dragging on the right lower limb, tandem walking difficulty.
Abdominal reflexes, sir?
Abdominal I did not do. Anyway, I should have looked for it. But being a female, I thought I'll not want to expose her. That's why I did not do it. Because otherwise, we know it's got ample evidence of a pyramidal lesion is there.
It is involvement of corticospinal and dorsal column involvement, sir.
Correct.
It excluded non-compressive lesions, person, any B12 deficiency or any nutrition risk.
Okay, perfectly right. There can sometimes we will say predominantly the upper limb side also. So it may be only confined to the upper limb posterior column, much more than the lower limb. It not always be in the lower limb. But what is a peculiarity here? If you think that it's got a weak. Pardon?
So JPS was impaired in both all the fingers and all the toes, sir?
Correct.
Sir, the patient has got the Georgia bricks.
Correct. That's another point. Georgia is brisk.
So if there is a bricks Georgia, as per standard teaching, the level should be above the level of the pons.
Correct.
Ideally. But otherwise,
above at least above the lower pons.
Lower pons. Yes, sir. So otherwise, all things could have been fitted into the upper motor signs. That means corticospinal involvement and posterior involvement, which may be explained in the cervical lesion. But because of the Georgia's increase, so at least the level of the lower pons, there should be something there. So in that way, we have to go with the DDs.
Okay, very good. Okay, that is a good thought. Very perfectly right. So what could be your site is one cervical cord plus above brainstem or same lesion causing both or only cervical cord? What could be the possibilities?
No, per cervical.
There are no intraaxial involvement, no, sir. Other signs of intraaxial involvement.
No other interaxial involvement per se. There's no Horner syndrome, no obstacular movements normal, bulbar muscles normal, neck muscles normal.
Then we can think in the cervical.
Maybe cervical cord, that's a dominant thing. But you see, what is the peculiarity in this patient? He's got a pyramidal signs, but the weakness is only in the upper limb. Significant weakness of the hand and shoulder abduction, but lower limb, if could walk normally, he only think mild flexion.
Sir, multiple level, we can explain that.
Okay, multiple level, how could I explain it multiple level? Again, if the lesion is the cervical cord, it would invariably affect the lower limb also. You mean to say that it's still difficult to explain, no? If you think of a pyramidal lesion in the cervical cord, producing upper limb, naturally it should have affected the lower limb also to the same extent.
So that is not the one. That is not the one which is giving the upper limb symptoms, weakness. That pyramidal that same lesion is not the lesion which causes the symptoms of the triceps. The triceps cannot become weak with that.
The point is what I'm trying that. See, we agree that he has got upper limb weakness, lower limb relatively normal. Okay.
Yes.
That's step one. Step two, whether it's LMN or UMN. It is UMN. Upper limb weakness is UMN. The upper limb weakness is UMN. The lesion has to be in the pyramidal tract above C5.
Yes, sir.
Right. So if the pyramidal tract is above C5, why it is sparing the lower limb muscles?
Central lesion, sir.
The medial. But it's
Okay.
medial only.
If the pyramidal tract is affected medially, so
Ah.
something like intermedullary lesion affect only the middle part of the pyramidal tract. Agree with you. Perfectly agree with you. But here the sensory is a posterior column. The posterior column intermediate lesions, usually the posterior column last to be affected. Moreover, such a lesion should affect the spinothalamic before the posterior column. Unless it is a non-compressive myelopathy.
So it could be non-compressive myelopathy.
Yeah, it could be. But the problem with non-compressive myelopathy is that, see, the posterior column is concerned, agree with you. There are two different tracts, the cuneatus and gracilis. Someday cuneatus tracts alone may be affected, maybe predominant upper limb involvement. Gracilis alone may be affected, maybe predominant lower limb involvement. But unlike in a pyramidal tract, in non-compressive myelopathy, how can it affect only the upper limb fibers? There's only one tract.
The crossing of the upper
cervical
limb
cord.
fibers, crossing of the upper cervical cord can involve the upper limb only, sir, because the lower limb fibers and the upper limb fibers in the cervical region, they have got different area of their disposition.
Perfectly right.
Cervical, high cervical cord before the decussation.
Right. That is the answer I wanted. You can have upper limb involvement in the high cervical cord when the decussate, because the upper limb fiber decussate earlier or more proximally than the lower limb fibers.
Lower limb fibers, they are lower down.
Correct. So that involvement can explain the problem. So that part is settled. So we can explain everything by a high cervical cord somewhere around the foramen magnum. Because not high cervical does not mean C3, C4 and all. This can occur only when the pyramidal decussation is occurring. That means in the lower medulla. Okay.
Yes,
lower
sir.
medulla. That's the site of lesion, not cervical
That
cord.
can explain the posterior columns. Medial
That
and
also, can also explain the posterior column. Okay. Now, the next problem is now the Bischogic. Let us see. So, how to explain the Bischogic? Same thing we answered. How to explain the predominant weakness upper limb that we answered. Can a foramen magnum lesion cause predominant upper limb weakness? Yes, the same thing which you already said. This is called cruciate paralysis. See, in fact, the term cruciate paralysis is used in two ways. One is a cruciate paralysis, one upper limb and one other lower limb. That is one cruciate paralysis. This also is called a cruciate paralysis, where you find predominantly upper limb involved. See, the black thing which is shadowed is the paralyzed upper limb. And see where the lesion is. This is the middle part is the fibers carrying the upper limb pyramidal fibers that cross earlier than the lower limb fibers. So when the lesion is compressing here, it only produces a bibrachial weakness. Lower limb weakness is minimal, if at all. Okay, this is one type of cruciate paralysis. That is weakness of both arms with relative sparing of the legs due to lesion involving the rostral portion of the pyramidal decussation. Similar to the central cord syndrome of cervical spine, the man in the barrel appearance that you said earlier. Okay. Now the other cruciate paralysis is this one. One upper limb and contralateral lower limb. That is because the lesion is not in the central, but on one side. It is affected already the crossed fibers of the upper limb and the fibers which is going to cross. That is the lower limb fibers which is going to cross the opposite side. When that is affected, you get a cruciate paralysis. Here it is this cord is cruciate. One upper limb, one lateral, that way. The other, both upper limb. For some reason, both the lower limb also can be affected because only the decussation is affecting lower down. So what investigation you need?
MRI.
MRI. So we can explain every foramen magnum lesion, but except for the Georgiac. Now, sometimes foramen magnum lesions can produce Georgiac if the lesion happens to extend upward. But it has to compress the brainstem, upper brainstem, as the doctor was here, Professor Sterling, it involved the upper part, invariably has to involve. Somehow it got in, either by ischemia or by some compression of some sort. So MRI brain. So MRI brain. See what has happened now? In fact, the contrast was done. I could not get the contrast film, only the non-contrast. See the need to wait. See the compression from the anterior part of the clivus, compressing the medulla. See the medulla and the upper cervical cord. It is not affecting the pons. I'll show the all sequences I will show. Lesion is extending up to the pons, but not above the pons. This is still sequence. And there are many flow-wards in that lesion. It's a highly vascular lesion there. This is a coronal. The lesion is more on the right side. That is where weakness is more on the right side. See the flow-ward there? Shifting the brainstem to the opposite side. This is an axial cut. Pons, medulla. So the lesion is compressing the medulla on the right side. There are many flow-wards around. This is a highly vascular lesion. That is cord is shifted to the opposite side. This is again the zoomed up view of that picture. The site of the large lesion there. Yeah. This is space sequence again to find out the clearly delineating lesion. See the degree of compression there. Medulla is compressed, upper cervical cord is compressed. Okay, that's the story of the patient. So I brought this case to explain why the upper limbs are predominantly affected in cervical. That's one of the explanation, how to explain that finding. Secondly, brisk object that we think the lesion is extending onto the brainstem or compressing the brainstem somehow. It's not really confined to the upper cervical cord.
Sir, we can call it as a bibrachial diplegia, sir.
Yeah, it's called bibrachial diplegia, correct.
Why no bulbar symptoms, sir?
So that's a difficult thing to answer. He has got a compression of the brainstem medulla, but only thing is lower part is more compressed. Other things will come later on. That's all what we can say.
So these are AVMs.
Pardon? But I don't know. Because we have to, the contrast has to come. And it does not look like an AVM because there is a mass effect there. If it has to be, could be, it looks like a highly vascular lesion. There is some, I don't know what the nature is.
Can it be chordoma?
Very unlikely to be chordoma. Chordoma, the picture is not like this. It arises from the clivus. Here it is outside the clivus, compressing the brainstem. Not only that, we cannot differentiate whether it is arising from the clivus or not. But the clivus bone, in fact, is intact. And the lesion is in the subarachnoid space with multiple flow-wards. That's also unlikely to be in chordoma. Other conditions, hemangioblastoma can produce multiple flow-wards.
Sir, could it be multiple cavernoma, sir?
Very unlikely. This is not the picture of a cavernoma. Is not like a presentation like this. It's not extra-axial, more like interaxial. Moreover, the flow-wards will not occur in cavernoma. They are called something like a popcorn appearance there. The draining large dilated veins will not be the same. That can occur. AVM can occur with that large dilated arterial venous channels.
Sir, in cavernoma, we can get the fluid level, sir.
Yeah, because there's a when you say bleed, you can have a fluid level. But inside the parenchyma, there will be a mulberry-like popcorn-like appearance. Inside, you can have a blood bleeding also. But such kind of flow-wards will not occur with the cavernoma. They can with AV malformation, it can occur.
So CT angio also is needed, sir.
Yeah, we are planning. In fact, this case I saw only just 5 days back. So I asked for a contrast study and angiogram to be done. But I brought the case not for to find out the tissue nature, to find out the localization. how to explain the upper limb weakness, how to explain the jaw jerk, etc. That's only reason why I brought the case.
Only explain the Georgia risk, sir. Breast Georgia, sir.
Only thing is they can explain that only the upper brainstem is also compressed to an extent, or by the shift to the this thing has somehow compromised the bilateral pyramidal tract above that thing. Otherwise, you can't explain the jaw jerk.
Is preserved here, no? Bones is preserved.
Once it's preserved, that means the stretching of the pyramidal tract muscle. That's the only way to explain. It is brisk in this. Now, curiously speaking, I have seen some of the inevitable anomalies having a brisk jaw jerk. Now, this I have noticed in many patients, but there is no adequate, even literature also says it can occur. They say very funny explanations like retrograde degeneration and things like that. Ischemia second due to this thing, a lot of funny explanations that are given, but none of them are a valid explanation. But this is seen in kinesiological gen. I don't know the explanation how. But to tell you, but frankly tell you, it has to be at least above the mid pounds, lower pounds.
Sir, in the hands, is there any myelopathic sign, sir? So in the form of your escape sign? Escape finger that was outstretched fingers when there is a difficulty in the adduction of the little finger.
No, I think that is not very obvious.
In this case, it was there, sir.
I do not remember to have seen that, but yes, but clear evidence of pyramidal signs are there in this patient, no? Finger escape sign only there. That is one of the earliest signs of pyramidal lesion, but already it's got a weakness, brisk presses, brisk finger pressing jack, everything is there.
Yes, sir.
Yeah. Okay. Shall we close? Any other questions?
Thank you, sir.
Thank you,
Thank
sir.
you, sir.
Thank you.
Thank you so
Good
much,
night.
sir.
Thank you, sir.
Good night, sir.
Thank
Good
you.
night, sir.
Good night.
Thank you,
Good
sir.
night, sir.
Good night.
Thank you. We see
Thank you,
destiny.
sir. Good night, sir.
Good night. Good night.
Good night.
Thank you. Good night.